Yeah, okay.
Now we're live. This is Senate Health and Welfare. We're back again. Here we are. Katie, we have some
You have some
changes.
changes, yes. So you have removed section 1 of the bill, and you now have your section 2, former section 2 is now section 1. This is the implementation plan, and you've added a new subdivision 7, which reads propose a related public service announcement program to inform the public and healthcare providers about the potential public health impacts of exposure to PFAS and actions that can be taken to reduce risk. I'm going to read that again since I fumbled it so badly. Propose a related public service announcement program to inform the public and healthcare providers about the potential public health impacts of exposure to PFAS and actions that can be taken to reduce risk. And then the only other corresponding change is updating section 3 to be section 2.
And then what happened to the web page? They were gonna put stuff up on it.
I deleted that section.
What do we think about that? Is that okay?
Yeah.
They already have stuff up on the web page. You want
They can propose content.
Yes, let's put that proposed content for the web page.
I mean, wouldn't the web page sort of be part of this public service announcement program potentially?
No, but I mean, it's different. PSA is
All right.
a real film.
And what's say content?
Yeah.
There you go.
Let's say content.
That's all right. Is that okay, Gary?
That's not good one, yeah.
Okay. I will get an edited version over to Kiki.
What number is this?
4.1.
All right, we're good.
Okay.
Thank you so much.
You're welcome.
All right, well, so when we come back to this bill someday after town meeting, I think we'll be able to look at a clean copy and vote.
Fantastic.
Oh, thank you. Thanks for your work. All right, so let's move on to Representative Small, who is here and is going to share with us some information about criminal justice response and drug use. 872, thanks for being here.
Of course, thank you for the invite this morning. For the record, Jamal Manewski, Associate on the House Human Services Committee. H72, talking about overdose prevention centers. So in the House passed version of H72, it's primarily focused on the establishment and protections around overdose prevention centers in the state of Vermont. But before I get into what overdose prevention centers are, though I think this committee is well aware, I do want to just acknowledge the impact of stigma on how we as a community view drug use. Drug use and misuse is too often disregarded and seen as a personal choice, which really fails to recognize the severity of the substance use disorder as a mental health disorder. And so the fact of the matter is that the drugs that are being bought and sold in Vermont right now are becoming increasingly dangerous and deadly. According to a December report from the Department of Health, they have seen an increase in the involvement of xylazine and gabapentin in fatal opioid overdoses. And the unknown combination of drugs, which I think we've tried to combat in previous legislation with drug checking, is really leading to these record-setting numbers in our state. I won't get into the numbers because I believe this committee is well aware that sadly, when we tried to pass legislation to do a study on overdose prevention centers, we were already looking at 180 accidental opioid-related overdose deaths. I think what was really chilling in the House for us was to recognize that for each one of us that sits in these seats, that is someone in the state of Vermont who has died. And sadly, we are surpassing that number again this year, where we have had already 180 deaths in the state of Vermont in just the last 9 months. And our neighboring states have also come to recognize the importance of this as a public health intervention. A few that I'll highlight is that in 2021, On Point in New York City made history in becoming the first organization in the United States to open and operate 2 publicly recognized overdose prevention centers. What we've seen from their establishment is that they have saved over thousands of lives and have had absolutely no deaths in relation to their programming. Instead, what they've seen is a really strong collaboration with the New York City Police Department and recognizing that the police department actually started carrying cards to make referrals directly for folks who were in active drug use to make sure that they could get connected to the services rather than taking them through the criminal legal system. What they also saw is that there was a significant decrease in syringe litter within the direct vicinity of those overdose prevention centers. I think sometimes we get into this not in my backyard, and they ran into the same thing where they were actually relatively close to a school. But again, the change that they saw was that instead of kids having to walk by, use needles on their way to school, they saw a significant decrease in that litter and more folks being able to participate in their programming. In 2022, we saw Rhode Island pass legislation for what they titled harm reduction centers. Which is the same as an overdose prevention center. I think we've used a lot of terminology over time. Folks might be familiar with safe injection facility or a safer consumption site. We feel like overdose prevention centers is a more robust way of describing the services that are provided, and also reduces that stigma. Since I know for myself, when I think of a safe injection facility, I think of someone actively using drugs and using a needle in their arm. And that is a really graphic and disturbing image to think of. While instead, these services are thinking about ways to reduce that harm, to provide education and safer use, again, to really keep folks alive. And then most recently, in December of 2023, we saw our neighbors down south, Massachusetts, release their overdose prevention center feasibility report. I think maybe they caught on to what we were trying to do here in Vermont, so they did the report for us. I'm happy to share those statistics with you. But what was resounding is that they found from the Department of Health in Massachusetts that this is an evidence-based, life-saving tool that aligns with the Department of Public Health's approach to reduce the harms of substance use. I highlight just what has happened here in the United States, but we recognize that overdose prevention centers have existed for nearly 3 decades around the world, including much of Europe, Canada, and Australia. And to step back and think about the kind of broadness of the services provided, and which is specifically listed in H72, is that the services are collecting used hypodermic needles and syringes, providing harm reduction supplies, answering questions on safer consumption practices, administering first aid if needed, and monitoring and treating potential overdoses, providing referrals to addiction treatment, medical services, and social services, education on the risks of contracting bloodborne diseases, wound care, safer sex, and proper disposal of needles and syringes, and providing overdose prevention, education, and distribution. I think prior when we were having these conversations, we thought of them really theoretically. We didn't get to hear from folks who were actually running these facilities. And so it was quite an honor to be able to hear from the program director at On Point New York City, as well as a more rural setting up in Alberta, Canada, where they have both a fixed and mobile site overdose prevention center. And when we were digging into the question of saying, what does preventing an overdose really look like? When we're talking about preventing overdoses in overdose prevention centers, 80 to 90% of the time, they are just using oxygen. That is the life-saving treatment, is simply giving someone oxygen, which is quite different from what we're hearing from emergency medical providers in the field. Right now, when someone is responding, our emergency medical providers are responding, they're having to use Narcan, which immediately puts folks into precipitating withdrawal. That's why we're hearing about this really aggressive behavior. Someone who was on the brink of death now has gone from using drugs to having absolutely none of that substance in their body. They're in significant withdrawal and are really quite upset. And that's when we also see more folks actually dying of overdose, because after going into that withdrawal, they don't want to receive emergency medical services. All they can think about is having their substance again, and they tend to overuse afterwards and are not getting the responses that they need, leading to these increased deaths. I really do want to point to the testimony received from Grand Prairie, Alberta. What was really unique is that they are a rural community, very similar to, but not the same as, Vermont. And it really allowed us the opportunity to see what the possibilities are when it comes to overdose prevention centers. As you'll see in the legislation before you, we want to put 2 overdose prevention centers in the state. We don't signify where they need to be because we know that the folks in the community will know best. And we also recognize that community buy-in is an important part of overdose prevention centers. And we also lay out that it can be a fixed site or a mobile site. I think ideally what we would love to see in the future is a conjunction of the two. What we heard from the space up in Alberta is that they had a fixed site first and then they expanded into a mobile site. And while they found that having a mobile site being able to move and go directly to where communities were using drugs, they felt that it was really important to have the fixed site as well to get them connected to those long-term services, not just preventing the overdoses, but getting folks on their pathway to recovery. Recognizing that we are providing immunity protections in this bill, and that the House Human Services Committee, though we like to think of ourselves as legalese experts, we did send it down to our House Judiciary Committee to review as well, and they supported the work that we had put into the bill. One other piece that I'll highlight, or 2 pieces actually, is how are we funding this in the long term? As you may have already seen, the Opioid Abatement Settlement Committee, as its highest recommendation, was to fund overdose prevention centers at $2.6 million, 1.3 million being allocated to each site. We see that as, yes, a relatively long-term funding source, since we'll have that for the next 16 or so years. But we were thinking in the long term for Vermont. And so in conversation with the Joint Fiscal Office, we became aware of the Evidence-Based Education and Advertising Fund.
My fund.
Is that your fund? I didn't even know that. It gets very confused with the Education Fund, so we really have to we get that vernacular down. But so what we propose in this bill is to raise the current payments from 1.75% to 2.25%, which will bring in an additional $1 to $2 million in revenue to really sustain in the funding of these sites. I will also acknowledge that there is about $2 million in its base funding right now to be able to get those pilot sites started. And I think the last piece that I'll highlight.
Are you saying there's $2 million in the budget currently, or are you saying there's $2 million in the fund currently?
Both.
Okay.
In our version of the budget, we have put in the $2 million and we have ensured with JFO that would follow through. We also understand the necessity of studying these interventions. I think that's what we've heard from the administration time and time again, is that we have not seen this intervention within small rural communities, and why would Vermont be the leader? I think on our end, why we want to see Vermont as a leader is because of the enormous risk of the drugs that are on the streets and the increased death that we're seeing in our communities. But we want to make sure that we are studying this to see its efficacy. And so we have a 5-year study within this bill. And it focuses on doing a preliminary 1-year study as folks are getting these overdose prevention centers together, finding the location, setting it up, understanding the landscape of what is actually happening in Vermont, and then being able to study for the 4 years following to see, is this having a direct impact? And we specified particular things that we found to be relevant to the discussion. So looking at the current state of overdose crisis and deaths across the state, looking at crime rates in communities where these overdose prevention centers may be established, as well as the crime rates following the establishment, the rates of syringe litter in those communities, the number of emergency medical service response calls, the rate of syringe service program participant uptake of treatment and recovery services, and the impact of overdose prevention center pilot programs on the number of emergency response calls related specifically to overdoses across Vermont. This would come with interim reports that will be provided to the General Assembly on an annual basis on or before January 15th. And with unless we put more funding in, that would commence or end on January 15th of 2029. We heard from a really wide variety of witnesses. Thank goodness for Zoom, so that we could go all the way to New York City and up to Canada, as well as understanding what is happening in the field right now. And I will just end by saying that the vote out of the House was 96 in favor and 35 opposed. And I'm happy to answer any questions that you may have on our work.
Well, you've answered a lot of questions. My question was what was the vote? And how did it come out of committee? Was that,
Out of committee, it was a 9-2-0 vote.
wow,
Yes.
okay, that's done a lot of work. Thank you. Yes, thanks for the comprehensive report.
Of course.
Senator Weeks.
Just a curiosity question. Is it 2.6 million per year for the program?
2.6 million is seen as the upstart costs.
Starting, yeah.
Yeah, the startup costs. Gosh, it is Friday. Thank goodness. For startup costs, I'm looking at about $1 million per year and continued costs.
And any age limits in this conceit, in the concept?
And in the bill itself, we did not restrict any age limits. We really do see the Department of Health as the leaders in public health. And so they are going to be focused on creating the regulations for overdose prevention centers in collaboration with folks in community. I will just note this did come up in discussions on the floor in relation to this bill. And I can say from both a personal end, but also for the folks who have been working on this, that we not see a reason to have an age restriction on overdose prevention centers. If anyone is going to be using drugs and is at risk of dying because of that use, we want to make sure that they're connected to the services that can keep them alive and get them into the treatment that they deserve.
Senator Williams.
Thank you for the lot of clarification in that presentation. So you said there's 2.6 million in the proposed budget, and then you said something about 2 million in a fund. What's the fund?
Oh, great question. So the 2.6 million was recommended by the Opioid Abatement Settlement Committee, which I think Senator Hardy may be able to give more information for you on as she's a member of that. But within the budget, we put $2 million through the evidence-based education and advertising fund.
Oh, that's your fund. So
That
was my other question.
And just to highlight that discrepancy between 2 million and 2.6 million, when we were putting this proposal forward, we did not have that full proposed budget that was actually presented to the Opioid Abatement Settlement Committee.
Good.
And so.
So the financing of it, I mean, it's in the budget now for $2 million and the source is the fund. Is that designated? Okay, and then there's also the opioid settlement monies that are out there and we don't know how that's gonna sugar off. And yeah, so, and then we also have a bill that I've been looking at and two bills, one for the opioid settlement and the other one for the fund. So we've got, there'll be some juggling that goes on. Certainly, the need is out there. Yeah. Question.
Representative Small, that was a great presentation. First of all, I just wanted to thank you and your committee for your great work on this bill. I think it's really important. It's one of my priorities. And we got great testimony, similar, I think, testimony that you got in the opioid settlement advisory committee. The work that they're doing in New York City is amazing. I don't know that if you mentioned, but also Rhode Island is moving toward opening an overdose prevention site. And it was unanimously supported by the Opioid Settlement Advisory Committee as our number one priority was to fund the opioid overdose prevention site. One question I have though is the study that you have in the bill, this sort of 5-year, who does that study?
Great question. So we are asking that the Department of Health will actually, this one. The Department of Health will contract with a researcher that is specifically has knowledge either around rural addiction or overdose prevention centers or both.
Okay.
So it will be an outside contract in collaboration. with the
Okay.
Department of Health.
And I think a study that was similar to that was done at On Point in New York City, and that's where all the data on the, lower crime rates, lower litter rates, lower overdose rates and I think there was a radius around that they studied
I think that was in British Columbia. They
No,
just
in New York
said-
City
and-
too,
yeah.
and I can't remember what it is, obviously it's very different in an urban setting, but it was like certain number of blocks around that they saw this real decrease in all these things, and we got testimony from law enforcement too, just showed how impressive it was.
Yeah, I would highly recommend that the committee hear from Dr. Brandon Marshall,
Mhm.
who's from Brown University, has been integral with the
Journalist.
Rhode Island, perfect.
Uh,
His extensive research of what has already been implemented in Canada and in the United States, I think will be really fun.
Yeah, so I think what we'll do is that we could probably have you sit here all day and finish the bill, but I think what we'll do is we'll have, Ledge Council Michelle come up and talk about what is in the bill. So further context, but thank you,
Thank
good
you so much
work.
for having me.
And just so you know, it's an age bill and we do want to give it our due diligence, so it probably won't be until after crossover that we finalize anything on the bill.
Happy to throw out there and
Oh, we're gonna use you. Wow.
Good morning.
Good morning.
For the record, Michelle Childs, Office of Legislative Counsel, and Representative Small did such a great job. She did most of my work for me this morning, so.
I thought that was gonna happen.
And I realized I've just got about 10 minutes, so I'll go rather quickly just to give you a little flyby of the language.
Please, that would be great.
Sure.
You
And,
wanna put it up for us? Do you wanna put it up on the
oh,
screen?
do you want me to? I
Yeah,
don't, okay. Kiki, do I have a link?
Okay. Yeah, we're finished at 10:30 and.
Oh, okay, I thought it was only until. 10.
We're getting some testimony from, one person on S98 regarding, the prescription drug. Some needs prescription drug force, we're looking at benefit reward, this benefit, investment return, ROI.
Yeah, so let's go to the chamber.
10:20. We'll have. Do you, Representative Small, do you like your testimony to be, on our webpage under your name?
if that would be helpful, I'm happy to send
It would be very,
that a lot for you.
yeah, because you've got a lot of consolidated information. You just send it to Keith. No? All right. Okay. Maybe make it teensy bit.
Okay, so we're gonna start out,
That's me.
Oh.
Sorry.
No. I was getting set up here. All right, here we go.
okay, you're probably first asking, why am I here?
I know why you're doing it.
And that is because, so the idea of this has been around for, as you know, like a few years. And it started out with the concept of providing limited immunity, immunity from prosecution for drug possession for an overdose prevention site. And so it was kind of in the realm of the Judiciary Committee. And for those of you who've been around for a little while, you'll remember, it might just be underlines.
Yeah, I think it was.
When the legislature established the Good Samaritan Law,
That's right.
probably about maybe 10 or 12 years ago. So in Title 18, in Chapter 84, in your regulated drug chapter, At that time, the legislature decided on the policy to provide limited immunity from prosecution for, in that case, for possession, dispensing, or sale of a regulated drug. If someone made a good faith effort to contact emergency services for someone who was overdosing. So the idea behind that being that trying to encourage people to reach out to emergency services if somebody was ODing, and that if you removed the possible penalties for, making that call for drugs on site, that would hopefully encourage people to reach out for emergency services. And so that is an existing provision in law that you've had on the books for a number of years. And so what you have in section 1 is building on that. I would say that if you do decide to move forward with this proposal, I would probably, now that this has kind of expanded and there's a lot more information in here, I just create a new section within that chapter. So I would just do a little redrafting because it's this part is kind of it's much bigger than kind of the limited piece, and I would just create a new subsection.
Sounds good.
Just as an aside. But it does follow the model for what you have under your current Good Samaritan statute, and it is in that, and it is added to that section of law. And so essentially what it says is that there are certain folks, people who are either using a safe consumption site, people who are staffing a safe consumption site, or someone who either owns or has leased a piece of property for that safe consumption site to operate, that they are not to be arrested, cited, or prosecuted for a possession charge. So it does not extend to dispensing and sale the way that that the other provisions do. So this is just around possession. And so you'll see that language in subsection J in subdivision 1. And that it's as long as someone is acting in good faith provision of overdose prevention sites in accordance with the guidelines that are adopted by the Department of Health, then they would be immune from prosecution under those circumstances. So when they get down to the judiciary language here at the bottom, that because there's a few little terms there that folks are even in judiciary aren't necessarily always familiar with. So there's a provision there in J2 that says that the immunity provisions only apply to the use and derivative use of evidence gained as a proximate result of participation in or with an overdose prevention site. And the idea there is that use and derivative use is a legal term of art that is used to provide immunity, oftentimes to witnesses if they are in a criminal trial, if they're going to be giving testimony and giving evidence, and the prosecution wants to encourage them to participate and to give that evidence. They offer them immunity so that if you give that evidence, we're not going to then take that evidence if you somehow implicate itself in some way and then turn it around and use it against you. And so the same concept is applied here, and that terminology is also used with regard to the Good Samaritan law. So essentially what it means is that the state cannot use evidence of someone's either using a safe consumption site or staffing it or something like that, use that as evidence to prosecute someone for possession. The state can use independent evidence gained in some other context and prosecute that person, but they can't use the evidence of the person participating in this safe consumption site for the prosecution. That makes sense?
And judiciary will look at this.
Yes.
Yeah.
Try that's rolling.
So, and maybe before they look at it, we'll get your fix on the section.
Sure.
Yeah.
So top of page 2, subsection K, Representative Small really kind of went through this, but K essentially talks about the types of services that an overdose prevention center would offer. First one is that it would be supervised by healthcare professionals or other trained staff, where persons can consume pre-obtained drugs. So that's obviously essential here. They're not dispensing. So a person who is going to look to use the services would have to come with their drugs. Second one is they'd be providing harm reduction supplies. They'd be answering questions on safer consumption practices. They would be administering first aid, if that's needed. They would be providing referrals to addiction treatment and medical services and social services. They'd be educating folks on wound care, HIV prevention and such. They would be providing overdose prevention education and distributing overdose reversal medications. They'd be educating participants on proper disposal of hypodermic needles and syringes, and providing reasonable security for the program site, and establishing operating procedures, as well as eligibility criteria for program participants.
Who's providing the security?
That would be something that an overdose prevention center would need to do as part of their plan. So we're gonna get to language in just a minute about the Department of Health is gonna be establishing the guidelines for these overdose prevention centers to apply to the Department of Health to be approved. And so that would be part of like the Department of Health would establish the guidelines saying, we think you need this type of security, and then they would come forward with their proposal. But it's not prescribed specifically. So you see top of page 3, subsection L. So Department of Health in consultation with stakeholders and health departments in other states that have these types of programs operating are to develop guidelines for the prevention centers not later than April 1st of next year. And the operating guidelines are to include the level of staff qualifications that are required for medical safety and treatment and referral support. Subsection M is around who can apply to. An entity can apply to Department of Health. They can operate more than one program. And as Taylor said, that can be provided at a fixed location or a mobile unit or both. And an existing safe syringe program is eligible to apply to be an overdose prevention center. Subdivision M2 is that if an applicant complies with all the laws, rules, and operating guidelines, the application is to be approved within 45 days of receipt. And if it's denied, then the health department is to provide that entity with a written explanation of, what was lacking in the application and kind of a path to how they might remedy that. And then that entity can resubmit the application to the department, and then that 45 days would start to toll again. And then once a program is approved, that approval is for 2 years, and then they would have to come back to Department of Health for renewal. Top of page 4, subsection N, is that an overdose prevention center shall be permitted to operate within a municipality only upon affirmative vote of the legislative body of the municipality. So you'd have to have buy-in from the municipality. Subsection O is a reporting requirement, so that an overdose prevention center is to make publicly available information on an annual basis every January about the number of program participants, de-identified demographic information about those participants, the number of overdoses at the centers, and the number of overdoses that were reversed, the number of times EMS was contacted for assistance, the number of times law enforcement was contacted and responded for assistance, and the number of participants who were directly and formally referred to other types of services.
Why don't we finish up with that? Because I see the next sections go on to the needle exchange.
Well, there's a lot more on overdose prevention.
Okay, why don't we, yeah, I'm thinking,
Are you watching time?
yeah.
I'll go quick.
Yeah.
So section 2 is just making a small technical tweak around the limitations on the needle exchange programs. And same on section 3, and just a clarification that a needle exchange program can apply to be an overdose prevention center. Sections 4 and 5 are the manufacturing fee that Representative Small already spoke about. So you'll see the fee is changing from 1.75 to 2.25%. And then, you'll see is the language is added to make it clear that that money can be used for grants, for the overdose prevention centers. There you have your evidence-based education and advertising fund, so just bringing that language into that. So section 6 is your appropriation from the evidence-based education and advertising fund. So as Representative Small already mentioned, in the House, it was designated $2 million for the purpose of awarding grants for 2 fixed site or mobile overdose prevention centers. Section 7 is the study. And so on or before December of this year, Department of Health is to contract with a researcher or independent consulting entity who has expertise in the field of rural addiction or overdose prevention centers or both to study the impact of the pilot project that is created in this bill. It's to evaluate the current impacts of the overdose crisis in Vermont, as well as any changes for up to 4 years following the implementation of an overdose prevention center. So you see there, starting in subdivision 1 on page 9, just read those, just kind of the things that the study is supposed to report back on. So it's everything from crime rates to syringe litter to EMS calls, those types of things. Then subsection B is the Department of Health is to collaborate with the researcher to provide the General Assembly with updates over the course of that time. So every year in January, they're going to issue a report to the General Assembly, letting you know what the information is that they've gained from the pilot project.
Is there anything in here about how the budget is being, how it's appropriated within the Senate? I'm sure that's something to think about. I am thoughtful about it.
And then section 8 is the appropriation of $300,000 from the opioid abatement special fund for the purpose of funding the study. Okay, so the pilot project is funded by the evidence-based manufacturing. Sorry, I still can't. We need an acronym or something for that one.
The manufacturers.
It's coming
the
from
manufacturers fee fund.
the manufacturer fee fund, and then the money for the study of the pilot project is coming from the opioid abatement.
Questions?
So that was my question. The fee, is that coming to the state? So are they gonna?
It goes to the Department of Health, it goes into the fund directly, and it is not, doesn't go through, it's really, has very designated uses. Initially, it was for drug detailing to encourage and have physicians understand the role that they play in prescribing oxycodone and other opioids. So that's what the original intent was, and so the manufacturers kept a keen eye on how we use that fund.
And you can see in section 4 where we amend that section, you can see all the permitted uses of those monies, and this is just added to one of those uses.
We've added over time different ones.
So before I should have asked this question first. It sounds like that there's gonna be a private entity that's running this, not Flanagan Coulter. It's not necessarily gonna be run by the state, is that correct?
The way the bill is written, yeah. And then the Department of Health will be writing out the guidelines for it according to the bill now. And then some of the, I know that we had very passionate testimony from a member of the Howard Center a few years ago, and that some of our DAs would like to be involved in this. So there's a lot that we need to learn. We're just on the ground floor with this, and we need to understand everything that is implied and people who are interested. Senator Dork.
Thank you. I'm so glad we're finally taking this up. This is really exciting. So I thank everyone who is here today speaking on this topic. To follow up on Senator Williams' question, I was wondering, as we were talking about entities that could apply, can a municipality be considered an entity? Can they apply directly, or do they have to partner with like Howard Mental Health or some other nonprofit or.
It's not specific in here. I think you probably just want to speak to some of the sponsors and other folks about
But we'll get,
what's
yeah, we'll
the
get
vision
testimony.
in terms of who's gonna provide those services.
Yeah, no, I was just curious.
Yeah, good question.
Just one more, maybe for Representative Small, but from a 30,000 foot view, it's, we're treating the symptom. And hopefully eventually this will go away. So is there any plan for the fund to go away if it does, or?
Great question. I would say Senator Lyons' fund will continue on in perpetuity. So the fund will exist, but I think that's why we have the study going out for years, is to see its efficacy and if it is still.
Okay. So if, maybe we could take, if it is successful, take some of that money and put it into prevention. I mean, eventually we're gonna have to deal with where this stuff is coming from.
So Senator, you're asking a great question, and as we look at this bill and S98 and others, we can make those kinds of decisions now, moving in the future.
Okay. Thank you. Thank you.
Thank you. It's great. Thank you. This is the first time we're seeing you. We'll see you again. I appreciate you being here. And we do want to very quickly thank you, Representative Small. We have about 10 minutes left, and we have Jane Horvath on Zoom with us to talk about the return on investment for a potential prescription drug advisory board. Jane, thank you for being here this morning. And so the question that we have is the value that this serves the state in terms of saving state dollars and or in terms of saving individual out-of-pocket expenses for folks who are purchasing prescription drugs. What's the return on investment for this?
So I don't know that we know that yet. It depends on the drugs that a board would choose to look at. I can speak generally sort of how it would work. So for instance, if there is, and I know your bill has been revised, I just saw it this morning.
Yes.
But so if there was an upper payment, state regulation of the cost of a particular product, so a costly product, and the product was regulated, and the cost to payers and purchasers in the state dropped 10% or 20%. You could figure that Medicaid gets their rebates and everything else, but Medicaid would save money when the pharmacist bills Medicaid. The pharmacist purchased the drug for 20% less and bills for 20% less. Same with state employees, they would see the exact same kind of savings in terms of the amount. It's called claims payment, right? So it's different than rebates and everything else that you get on the back end, but it's the transactions between a doctor and the plan, or the pharmacist and the plan. And so that kind of claims payment savings would apply to all your state agencies that either purchase the drug, if it's a public health kind of drug, for instance, or if it's a drug that is used in your Department of Corrections, they would all see that kind of savings. So direct purchasers, and then health plans in terms of their claims payment. So that's the direct kind of things that you can calculate very specifically. And then on the Medicaid side, nothing would change about your rebates. That's federal law. Those are big numbers that are calculated nationally. They're not specific to Vermont. So all of that would stay the same. So go ahead.
No, go ahead with your and then we'll get to Senator Williams. Go ahead.
Okay. So, and I did want to tell you sort of what might be helpful is I've sort of reviewed everything that for Oregon and Colorado, who have been the most active in thinking about actual drug products that are considered not affordable to either the healthcare system or patients through their cost sharing, or both. Okay, so there's different criteria that these Colorado and Oregon are using. And their criteria, how they look at a drug depends really on the drug, because drugs are all different in terms of how they're used and where they're placed on formularies and things like that. So, but those are sort of the two overarching constructs of them looking at these drugs. So Oregon has determined that Homolog, which is a highly concentrated, very strong dose of insulin for people who have a pretty serious diabetes, very insulin resistant diabetes, that is not affordable really on the patient side of things and the healthcare side of things. They've also determined that Trulicity and Ozempic, which are sort of in the same class of anti-diabetic products, are also creating affordability challenges. And they decided in their last meeting that Shingrix is it's a shingles vaccine, basically.
Yes, yes.
And that does not pose an affordability challenge in the state of Oregon. And the universe of drugs that Oregon is looking at are drugs that health plans are required annually to report on, like the 25 highest utilized drugs, the 25 highest spend, like total spend, and then the 25 most expensive products in terms of price. So all the plans report this into the agency, and then the agency looks at all of that and starts pulling from that annual report, basically. So that's where they get the drugs for their consideration. Now, Colorado hasn't looked at as many drugs as Oregon has. They have found that Genvoya, which is an HIV product, it's actually an older HIV product relative to what's on the market today. They found that to be affordable. Everybody talks in double negatives. I'll just say to be affordable. So that is affordable. And then they also found Trikafta, which is a drug that treats, it's a very effective drug, very good drug for cystic fibrosis treatment.
That's a good one for us to know, because I just got an email about that one. So this is extremely helpful. Someone-
Yes.
Can you send us this information, in bullet form?
Yes, I can. I said I would try to get to it over the weekend. I apologize. I'm
That's
just
fine.
really stacked.
That's fine. I think you've begun to answer the questions that we have, and I would appreciate this.
What did they find on the cystic fibrosis medicine?
That it is affordable. And the basis of that, I think, is interesting that you might want to know, which is for Genvoya and Trikafta. They found it to be affordable because of the incredible amount of pharmaceutical cost-sharing assistance. So Genvoya, when I looked at it last, which was a couple of years ago, they give up to $15,000 a year per patient for cost-sharing assistance. To me, that indicates that the company knows it's actually not affordable, but Colorado made a very different decision. So that's how I'm saying you can look at things different ways, and your metrics, how you evaluate things, can be very different. Trikafta,
Jane, I really, we're being called to the floor, so.
I'm sorry.
Senator
Okay.
Withers,
My question's for you.
my question is for you. Okay, so, if you could send us some of this information, that's helpful. You've answered the question, and the way we're looking at, and analyzing drugs appropriate to Vermont patients is, really resonates with what we've been thinking about, so.
Okay,
I appreciate your taking time with us today.
sure, absolutely.
And this isn't the last time, I'm afraid, but your expertise is really welcome in committee. Thank you so much.